welcome back, everybody. It's time again for another episode of Health Talks with Dr. TRINH. The one show, maybe the only show, that shows you the path to a healthier life. One guest, one conversation at a time. Today we're continuing a conversation we sort of veered off into last week about mental health in the healthcare industry here, and the whole notion of who's keeping the doctors healthy here. Burnout, stress. Last week we talked about the importance of a good relationships and how do you find love and romance in the white coat industry here? Or are people just supposed to be robots and exist 24 hours a day for their patients here? All that leads to our conversation. Dr. TRINH, you're on a trend here. What are we talking about? Is there burnout? Is there stress in the healthcare industry?
Is there burnout? I'm not sure. I'm kind of burnt out, so I got to think about it. No, I'm just kidding, guys. Yeah, I'm so glad to have Sue on today. Met Sue a number of years ago, pre-pandemic, right? Before the pandemic.
Yes, pre-pandemic.
Pre-pandemic, and I know Sue has leadership roles at UC Irvine with academics and education, and wanted to have Sue here to discuss a very important topic, a topic about physician burnout or burnout in healthcare providers. And it's one of the reasons why you can't find a good doctor today that you can get in next week when it's like a 3-month wait. It's because there's not enough of them going around. They're burning out with that. Yeah. Is that about right, Sue?
Absolutely. And sadly, by the way, for them as well as for all of us, this is a crisis that affects every human being. This is not just something that's a one-off in an industry that is, you have to opt into, out of interest, right? Everybody at some point in their life is a consumer or a patient, in healthcare. So this is important for everyone.
So who keeps the healthcare people, workers, healthy? We assume that they're there. We need them. They're needed more than ever in the last couple of years. They can't get COVID. They can't get sick. They can't be down. They can't be depressed. They can't quit on us. We need them now more than ever. And yet we don't look at them as human beings. We look at them, I think, too often as supermen, superwomen, or robots that are just there.
And by the way, sorry, this is Roxy. She loves Zoom, so she clearly likes the sound of your voice, Paul.
I have that cats and dogs follow me through the streets. I don't know why. But.
She's a COVID cat, so she's grown up, with Zoom, so she loves it. So let me answer your question this way. And the answer, first of all, to your question is, they can't, but they are. They are getting sick, and they are getting stressed, and they are getting burnt out. So they can't, but they are, right? They can't because we need them, to your point, but they are because they're human. So there are multiple aspects of health, right? Physical, emotional, spiritual, etc. So I was particularly interested, Paul, in the notion of burnout, because it actually is not a mental health issue. So let me start.
That's a bomb. That's a bomb that you dropped right away here, because we just assume it's just fatigue, it's just overload, it's just too many depressing stories. It's all emotional. It's not. I mean, it's all.
Those are all true, but that's not a mental health. So we're not talking about depression, anxiety, those kinds of things that are clinical and clinically diagnosed mental health issues. So why don't I start with the World Health Organization's definition of burnout, which was adapted from Dr. Christina Maslach, who developed the Maslach Burnout Index. So it is basically a normal stress reaction to dysfunctional workplaces that are poorly managed. Okay.
So you're putting the blame on the workplace and not the worker.
Correct. Huh. So there's no question that burnout, we've come to learn that burnout is a systemic issue first. And Dr. TRINH Dung will tell you, we have to stop saying doctors need to be more resilient. They're already quite resilient. All you have to do is ask them about medical school, right? And their residencies. And they showed up in the profession as resilient. So can they get better at not getting into fight flight in response to an angry patient? Sure. Those are skills. But let me go further with the definition, Paul, if I may. Okay. So there are 3 components, according to the World Health Organization definition. There is that physical and emotional fatigue that you were talking about. So being tired isn't a mental health problem, right? There isn't something dysfunctionally wrong, such as what anxiety does and what depression does, which is kind of distorts things because of the hyper emotionality. So it's normal physical and emotional fatigue from what people are facing. It's also kind of a psychological distancing. So it's not dissociation, which is a mental health issue, but it's kind of a distancing of so let me give you an example of that. A good example of that, and Dung, Dr. TRINH, you could probably relate to this. If you're trying to help a patient and give them advice, and they say to you, well, look, doctor, I looked at Google and my WhatsApp group says that, that's not that right, or the side effects are worse. You'll probably start to, lay out the facts and try to convince them. After being exposed to that day in and day out, for years at a time, at some point, you just kind of, give up and just say, look, I'm going to try it. Make the suggestion, give you the rationale, but I'm not going to push anymore. I'm not going to go for that. So it's up to you. So there's a lot of your Dr. Google does not exceed my medical degree and experience right out there. So that's that distancing that we're or cynicism is another way of thinking about it. And so you've got the exhaustion, you've got the cynicism and distance, and the third is a reduced sense of self-efficacy. So fancy way of saying people are not feeling as good about what they're doing, and they don't feel like they're doing their best as they used to. And often it could be because of the prior 2 factors in burnout. It can also very much be because of some of the systemic issues that are taking place. So where we are now in our understanding of burnout in the healthcare industry is we've gone from an awareness that it exists, and it predates COVID. We know that it predates COVID. An example, again, I'll ask you, Dr. TRINH, to weigh in on your experience with this, with the electronic health records, right? Yep. So the good news is that the technology is getting better. That, of course, means, in investments, which hospital systems are cautious about because reimbursements rates have gone down, which is another systemic factor in the external environment. So we do know that so for some of these factors, there's been an awareness. So the next step, and this really kickstarted in the COVID era, was for that kind of chief wellness officer role to be created and to be focused on the individual, like you were saying, Paul, like taking a look at that. So they were, and I'm going to just use some examples. There was free meals. There was yoga classes, meditation classes, quiet rooms, right? Access to mental health counseling, etc. So what that ended up being, Paul, is it ended up being necessary but not sufficient. It kind of did what William Ryan many years ago called blaming the victim. Right.
Exactly. I think that's what that's been my impression, is that at the heart of this, yes, there's a system that asks too much and demands too much of a physician's time, effort, emotional distance, and eventually they just succumb to the pressure. But the principle up to this point, I don't blame the workplace. It is what it is, like the military. It is what it is. It's a stressful environment. And instead, I'm talking to the doctors who aren't taking care of themselves, aren't getting exercise, aren't having healthy relationships, aren't distancing, aren't backing off once in a while to take a break. So the responsibility seemed to lie with the physicians or the people in the medical health facility, medical health world. It's up to you. You're in a stressful environment, so deal with it and deal with it better. It's up to you. We'll assist you. We'll help you, but the responsibility is yours to find out how to keep yourself healthier. I'm hearing the opposite. I'm hearing, hey, these people are human, and what do you expect them to do but burn out when you've got a burnout system?
So what I would say to that, Paul, is it's both and. It's not either or, right? And that's why I'm seeing you smile, Dung, right? So that is the third element of it. So there came to be an awareness, and the awareness of the burnout was in the increase in turnover, in people leaving, both physicians and nurses, by the way, leaving the profession, in increases in medical errors, and that also kind of resulted in the quality system that healthcare organizations, hospitals, aspire to achieve. But the systemic issues started ringing very loudly as some of the causes. So it isn't either or. People still need to exercise, but if there are staffing shortages, and the way that that's being solved at the physician level is to give them more hours.
Yeah, right.
They're not going to have time to have healthy relationships and exercise, and that is what they would say. Now with the advent of telemedicine and how that's been increasingly accepted since COVID, some physicians have been able to, and that's the meta-health work that Dung is getting involved with. There are some doctors that absolutely can take advantage of that, and that's very helpful for. So one of the things I also found is that women physicians who have younger children are not finding that there is support in the workplace. So just like any other workplace, they're getting extraordinarily stressed because they're still dealing with child rearing at home and dealing with that at home, even with the support of a spouse or a significant other, but they're not getting that support at work. So they're they're being torn by two worlds.
Let me give you an interesting take. So last week, Dr. TRINH sprung one on me. I thought, this is the craziest thing we've talked about. Romance in the white coat industry here. How do you find love amongst the bedpans or whatever here? And
among the bedpans.
Well, I'm being sensational here. I'm trying to make it people go, what? Anyway, and it was a young woman doctor that he's known, and she's single, and she said, I work 80 billion hours. I can't just go out and meet people like others do. And if I do, maybe I have a different sort of expectation, or maybe I need a different partner. I can't just, I probably have to have somebody who has some educational match to mine, has some understanding of the industry. Otherwise, I'm always explaining everything, is accepting of long hours, and I'm away a lot. And, certain requirements that make it difficult for them to find relationships. And without healthy relationships, then they're going home to nobody. And why are they committing suicide? Why are they dropping out? Why are they burning out? Because their work is very fulfilling, but those hours when they're alone are very unfulfilling and very lonely. And we don't, and she says, every other place you meet people in your work environment. If I work at a factory, if I work in an office, if I work in the military, I probably meet others in the field. And she said, but I'm not working with other doctors. I'm not working with other, maybe nurses or something, but I'm not working with other doctors. I'm working alone all the time with patients. And I can't date my patients. not, she said that not some patients haven't tried, but she said, it's an awkward relationship if I'm going to be examining you and, oh, by the way, hey, you want to go out for a drink or something?
Yeah, later. They can't do that. So you said a couple of really important things there, Paul. And by the way, that affects people of all genders, not just women.
Yeah, clearly.
Right. Yeah, clearly.
Although she did think that there was extra pressure on women, she thought it was particularly hard.
I don't know what the research says about that. I'm more familiar with women's physicians who have younger children. Yeah. I'm more familiar with that. I'm not familiar with the single world. But why is she working 1 billion hours?
She's a doctor.
That's the question. She has the resilience, right, Dr. TRINH? She has the resilience to do so. And she has the ability and she's willing.
And she's had the training, because medical school is a marathon. Medical school is a, what do you run when you run down the middle in the Indian tribes and they beat you as you run down the middle? What do they call that? I don't know.
Never heard of it.
Anyway, but it's this idea of it's a stressful situation from the minute you go into medicine. They expect you to work 1 billion hours, inhuman hours. You get 2 hours of sleep when you're in medical school because you're studying or you're being an internship. So big surprise if you survive and come out of that on the other side as a successful doctor or healthcare provider, then it seems natural. I'm just going to continue to do that and work. That's what I did for the last 6 years in medical school and internship and all the other stuff here.
Yeah, good point. I would say that I would ask how sustainable that is as somebody ages. Right. And as that, most people when they go to medical school are in their 20s and they are single. There are, of course, exceptions to that, but that's the vast majority. So, that's not necessarily sustainable as people go through their career. But clearly the people, as to kind of go back to what I was talking about earlier, the people who are, for example, primary care physicians are able to do telemedicine.
Yes.
And so that's an example. If you are a caregiver of small children, that's really helpful. It helps with that flexibility and adaptability, which is very much needed.
Somebody just tweeted in gauntlet. Gauntlet was the word I was struggling with. When you run the gauntlet. Yeah, right.
Yeah. If you're doing hands-on work, like you're a surgeon or an anesthesiologist, you don't get that privilege.
No. So right? I'm just saying in the I guess it started in Indian tribes. This idea of running the gauntlet was a test of strength and will. You would run down the line and people would pelt you with rocks and hit you and everything else and do whatever they could. And if you survived and made it to the end, then you're a successful member of the tribe or you've won. You run the gauntlet. And so they asked doctors and nurses to run this gauntlet, this inhuman torture test of hours and time and everything. And then at the end, why do we expect them to slow down and not continue it? That's how I got here.
And I do know that there's talk in the medical school community about adjusting that model. I mean, especially when they're doing their residencies, and not having to be up, for example, for 48 hours. But the other thing that you touched on, Paul, that I thought was very important was what we mean in the research on the definition of well-being. So you talked about this person who is very fulfilled. The career is full of meaning of being in health promotion, disease prevention, and disease diagnosis and treatment, and all this stuff. Right, being a healer. Right. It's deeply purposeful and meaningful work, and that is actually one part of well-being, is having that kind of deeper connection. That is not necessarily correlated with the other one, which is kind of more that, how happy and joyful I am, kind of the emotional kind of ups, right? So, a doctor who is who's in the ER and saving life after life after life, a doctor like Dr. TRINH who's doing work in Alzheimer's, right, is, he probably gets some joy from seeing people responding to his work. But it's very serious work and very, very
I don't
purposeful and
remember.
meaningful.
Sorry.
Yeah. So purposeful and meaningful. So well-being, which is, obviously what we're going toward from burnout, has those two components. It's the happiness, joyful index, and that's your point, Paul, about having people to go home to, having relationships, having friends, having a social life, having family, whatever that hobbies, exercise, all that stuff that makes us joyful and happy. So that's one part of well-being. And the other one is purposeful. Part of what's going on, which is also part of the tragedy of this crisis, is with all of the misinformation and disinformation that's out there, and all of the false affronts of experts that are out there, right? Whether they're on your WhatsApp chat or they're somewhere, in your Facebook search. Doctors are starting to get a sense of, what am I here for? What am I doing this to myself for? If patients are going to be resistant, they're not going to, take my advice. If I'm going to be, and this is a systemic level, Paul, in hospital systems, they're starting to feel commoditized, right? They're not feeling as respected and revered, not just by patients and patients' families. But the same within the organization.
And we've argued on this show.
More like
we've argued on this show. I think Dr. TRINH, maybe me more than Dr. TRINH even, that the medical healthcare system has turned into a commodity. It's turned into an assembly line. Next, I know you really need some more time here. I maybe need more time to think about this, but time's up. Next patient, let's go. I can't get compensated for more time. My people who run my practice, I got a backlog of people because there's a shortage of doctors. Medicare only pays me for a certain amount of time, and so it becomes an assembly line. It becomes a checkout line, and you bring your problem. He or she quickly looks at it and makes a determination, and then on to the next. And in that system, I no longer look to my healthcare provider for anything more than rotating the tires, changing the oil. I come in for a specific purpose, take care of it, I leave. We don't have a conversation about my lifestyle, about my health, about my mental health, about anything else that I used to talk to my doctor. The doctor was my priest, my confessor, my psychologist, my therapist, my advisor, my health advisor. And now they don't have the time to do that. So as they reduce themselves down to being just a service provider, I doubt whether people view them in the same authoritative stance. The guy that rotates.
To walk a fine line, right? Because it's not just the individual provider; it's the system, the healthcare system. The hospitals aren't getting reimbursed. Right. So they're needing, and reimbursements are not keeping up with inflation. And this is at the Medicare level as well as the insurer level. Right. So they're needing to deal with escalating, labor costs, escalating capital costs, and needing to, keep up technologically,
and a pressure on everybody for financial stability. Let's reduce costs. Let's increase outcomes, but by all means, let's reduce costs, because we've long felt that there's too much waste. And Bill, I'm doing 12 tests, and maybe I only need to do 2. And so we're running up the bill. Maybe that benefits the hospital. Maybe that protects the doctors in a litigious society, not getting sued. So I'll do 20 tests instead of 2 tests. So I've covered everything. But in the end, it's driven this backward pendulum swing to control costs at all, and partly because costs are ballooning. We need to control costs, and that means it turns into a quick experience and a very limited engagement. And in that sort of environment, I could see that I just sort of feel like a checkout cashier or somebody just on the assembly line putting the next piece, and then the car rolls by. So that
and you're right about that, because before there wasn't a sufficient accountability.
Right.
We didn't know what everything cost. So it has swung now to the other side. But here's the thing, and I want to give you an example from today's headlines. In New York City, there was a nursing strike at Montefiore Hospital in the Bronx and in Mount Sinai Hospital in Manhattan. And the nurses went on strike with the nurses union for two main reasons. One was, of course, pay, because they hadn't gotten increases in pay, and so they won that. But their number one issue was what? Staffing. Yeah. And they're actually, if anybody's interested, they made a video that's on the New York Times website, just interviewing nurses and their experiences with it. So the concept of moral injury comes up a lot. So moral injury being doing kind of your examples, Paul, were spot on, right? Doing things that are not what you should be doing. So if I'm a physician and I only am allotted 15 minutes to be with this elderly patient who clearly has a number of things going on, I know that accelerating and going at a fast pace, especially if they're alone, right? They don't have somebody who's there advocating for them, is going to not serve them well. And I didn't become a doctor to do that. I became a doctor to spend quality time to be a healer.
Right.
At the end of the day, that's my idea. So the identity, the self-identity of people going into this profession, whether they're nurses or they're physicians or any of the other roles in healthcare, is as a healer, caring about people. So
let me ask you a hard question for both of you. I'll start with Dr. TRINH, and then we'll go back to Sue. If the system is at least partly responsible, maybe it's half of the responsibility, is we've built a system where burnout is almost inevitable. Too many patients, too short a time, diminishes your feeling, and why am I doing this, and what am I putting myself through this stress, and all these kinds of things. A medical system that's built up, et cetera, et cetera. A medical training system that teaches you to run the gauntlet and survive with no sleep and put 1 million hours in. From the minute you start down this path, you're taught that's what a doctor does. All these things that are built into the system here. Whose responsibility is it to change? Is it the medical system is just going to wake up and say, "Oh, we're losing doctors, we got to do better," or is it the doctors and nurses who are going to go on strike and say, "We're not putting up with this anymore"? Or is it somehow the patients who are putting up with this and saying, "I'm going to opt out. I'm going to go elsewhere. I'm going to look for alternative models. I'm going to look for alternative medicine"? Who steps up and changes this? That seems to be the problem. Everybody moans about it, but no, it's like, who was it? Mark Twain said, everybody complains about the weather, but nobody does anything about it. It's the same thing. Everybody complains about the healthcare system and this burnout model, but I don't see anybody changing it. So, Dr. TRINH, who stands up and starts the revolution? Who changes it?
The revolution is being started by Sue.
Dr. Sue, okay.
With her data and her research. And her research shows that healthcare providers are retiring early and burning out. And they're put into a system that is probably designed, obviously not by patients.
No.
And the system's probably not designed by doctors. Maybe it's designed by bean counters or business people, I'm not saying that, these are bad people, but the system is maybe designed with financials first, right, rather than patients first. Right. And so perhaps we need to take a second look at that. Patients always have the last say, actually, in the system. Right. I mean, when we think about, let's say, for example, the incentives of healthcare. Doctors are actually incentivized to see a lot more patients for different reasons.
And one is financial. They make more money because it's a pay for service. And one of it is a pressure by their hospital.
Health plans are incentivized.
Yeah. Get them
financially, hospitals are incentivized. Who's incentivizing the patient to keep themselves healthy? Who is actually, the patient is the pawn in this whole system. And that's where the problem starts. So I think we need to kind of take a second look, and which is why MD DAO was started, right? To kind of create that grassroots, decentralized, autonomous organization where the patient has a voice to redesign the system in a way that's patient-centric and not necessarily, being counter-centric.
I'm going to go one step further, where the patient is incentivized to participate. I think one of the other untold reasons that this system survives is that I don't know what it costs, and I don't pay for it. I have an insurance either provided by the government, Medicare, or provided by me through a payroll, and I just go, and I have no idea what it costs or if there's a cheaper or a better way to do it. This is what I'm handed. They pay for it, and then I just show up and complain about it. Gee, I'm getting lousy service here. But there is no other alternative for the most part. People have experimented with, I'm going to pay the doctor directly and other sorts of things and other models we've talked about here. But the idea, the Supreme Court said this when they upheld the Affordable Care Act, and everybody was arguing, well, you're forcing people to do this, and it's not. And they said healthcare is not like every other service. You can't just simply walk away. What? You charge that for heart? I'm not doing it. I'll go down the street and get somebody else to do it. No, in the meantime, you die. You can't just shop around in the same way you shop around for different tire companies or different toasters. You're in demand right now. I need it. I'm having a heart attack right now, and I can't sit and debate what you're paying for this thing here. So I think until the patients stand up and say, I want something different, and I'm not going to put up with this system anymore, or embrace an alternative if there are others out there, I think this is just going to go on. And what makes the patients not scream is that they don't feel the pain. They don't know what they're paying for. It doesn't come out of my pocket. I don't care if you run a 50 test. I don't care, run 100 tests. I want every test I can get. So what do you think, Dr. Sue? And we're throwing out a lot of stuff here quickly, but I go back to the central question. Your data shows there's a broken system that's causing burnout. And this burnout has real life consequences. Doctors are quitting. They're retiring. They're committing suicide. People aren't lining up to follow them into medical school. And so it's a bad system's only getting more backed up here. Whose responsibility is it to do it? Is it the bean counters, the financial people who built these models on a financial model? Is it the patients who say, ain't going to take anymore? Or is it the nurses going out on strike and saying, we're not going to do this anymore?
A couple thoughts. So first of all, I would never call the people in accounting bean counters.
We do, because we hate accountants.
They're some of my favorite people because that is a skill set that is probably like the lowest on my capability. So I'm very grateful to them. So,
we all hate bean counters. They just count beans. So what is it they do? Yeah.
Secondly, so your question has some false choices to it because it isn't, is it this or this? It is this and this. And that's what makes the problem so complex. It didn't happen overnight and it's not going to get solved overnight. And, patients have already been getting agency from doing their quote unquote research online. And who are they attacking? Right? Who are they self-advocating to? The people who don't have the agency to make the change, the physician who's just trying to heal them. So they're going to the wrong place. So let me.
I don't complain to the hospital. I don't complain to the the insurance agency. I go scream at the doctor. What do you mean you don't have any more time? Well, what about this? Well, what about this alternative?
And the doctor is just doing what they're prescribed, especially, by the way, especially the frontline doctor. I'm really focused now on the frontline doctor. If we're, the chief medical officers, the people who are in leadership, they're facing a whole host of other pressures.
Right.
But so I want to stay focused on the frontline physician. In answer to the other answer to your question I'd like to share a resource. So thank you to Dr. TRINH for the accolades to my research, but there's a whole boatload of it out there, and a lot of people who've done incredible work in the area of healthcare burnout. One important go-to is the Surgeon General of the United States, Surgeon General Murthy, put out a report last year, and let me read the title correctly. It's Addressing Health Worker Burnout, the U.S. Surgeon General's Advisory on Building a Thriving and Healthy Workplace.
Wow.
And here's just to give you, Paul, just the landscape. He talks about the issues like we have, and then he says we must take actions, what healthcare organizations can do, what federal, state, local, and tribal governments can do, what health insurers and payers can do, what the healthcare technology companies can do, what academic institutions, clinical training, and accreditation bodies can do,
wow,
what family members, friends, and communities can do, what health workers can do, and what the media can do. So, and he also
a lot of stakeholders in this game here.
Yes. So that's why your question is an excellent one, but it isn't either or, it's both and. And so what we've learned about burnout, and by the way, not just in healthcare, right? I mean, we could talk boatloads about it in education, right? So in policing, I mean, it's pervasive in multiple industries, but we're focused on healthcare,
particularly high stress industries where the pressure is great, life or death.
Service. So you have an awareness. And then we went from awareness to a focus on the individual, and what ended up happening was physicians like Dr. TRINH were saying, you can't yoga your way out of this.
Yeah, right.
Right? There's no Om meditation that I can do that's going to solve the staffing problem and putting in 1 billion hours and having a sense of purpose and meaning, but no joy and happiness in my life, right? So I'm not thriving fully. I have an incomplete life, because of this. Now, so we know now that it's a systems issue. Right? That's at the macro level, at the government and insurer level, at the organizational level with staffing models. So these 2 strikes in New York that started Monday, they ended today, thankfully, are addressing, the staffing shortages in nursing because people are dying and nurses are, going home exhausted, right? And being less capable of doing their job day in and day out. So, and same thing with staffing models for physicians. So what they do, Paul, with nurses is there's such a thing called traveling nurses.
Yes, right. We've had one on. Right.
Is becoming very, very popular to replace staff nursing shortages. So basically, nurses have decided, you know what? I don't want to work for an organization anymore. I just want to be a temp. So they're making more money, which the staff nurses resent and which the doctors support, right? So now they're against the travelers, and the traveling nurses are not getting onboarded. So they're being, they're walking through the doors of, say, an ER, and they don't have a login into the system. They don't know where the supplies and equipment are, and then they're being blamed, of course. And the doctors are being forced to kind of be mediators, in all of this, and kind of step in when they're, when they've got their hands in somebody's chest, as
talk about that for a second, Dr. TRINH, because we're talking about a broken system. We're talking about a system that needs some real serious rethinking here. If it's not going to burn out everybody, it needs rethinking. One, because it's still incredibly expensive. 2, it needs to be rethought because the patients more and more like me are saying, I don't like going to the doctor. I'll do anything but go to the doctor. And when I do, I'm not sure I really get good quality service because I only see him for 5 minutes or 15 minutes or whatever. And he gives me a pill or a procedure. That's his only alternatives here. So more and more people, my aging baby boomers, were looking for alternative health ideas. We're looking to just avoid doctors wholesale. And when we go to the doctor, I'm not sure I listen to him. As Dr. Sue said earlier, I'm not sure I listen to him anymore here. I'm not sure I even accept their advice. So it's broken for cost. It's broken for the way patients feel about it. And what you guys are saying, it's certainly broken in what it does to burn out the people in the system. So if all of this is true, if all of this is happening out there, again, I try and figure out, how do you rally a consensus to change something? And at the root of it, is it pay for play? Is that the fundamental flaw in the system, that we're paying? We should rethink how we structure medicine in this country, whether it's government supplied or whether it's patient paying them directly, or this notion that somehow everything I do has a charge attached to it, and therefore I'm trying to maximize the number of people I see and minimize the amount of time I see with them. Is pay for play, is pay for service at the core of this thing?
Yeah, maybe take a step back to look at the process of how healthcare is delivered. The interesting thing is we take care of a lot of folks who are older, right? Seniors, right, with memory problems and concerns about their memory and Alzheimer's and dementia. And for a patient like that, just to get to the doctor's office, it is not easy. It starts with a phone call with the staff. Sometimes they're given multiple options of which button to push. And then if they get to a human, then they're put on hold. And then they got to decide on an appointment date.
Which is weeks out, maybe.
Which is weeks out, months out.
And then they got to get there.
Then they got to get there. Yeah. They got to figure out transportation if they don't drive. They got to hit the freeway, right? They got to go on the 405 or the 5. If the patient's working, they got to take time off work. Mm-hmm. If they have a small child, they have to find childcare.
And then they got to wait when they get there.
And then they get to the doctor's office, and then they wait again, right? They're in the waiting room. There's paperwork to fill out. There's more waiting. And then they go inside the exam room, and then there's more waiting. Mm-hmm. For that 5 to 10 minute encounter with the provider, right?
How much time, energy, misery did I go through for that precious 5 minutes in front of the doctor?
And when you think of that, you think of, mapping out the steps, mapping out the process, and to determine where in this entire process is there value between both the patient and the doctor. Right. And the value steps is probably the smallest steps, the 5 to 10 minutes.
Yeah.
In this entire process.
That's all I'm going for. That's all I wanted. That's all I need. Maybe I need more than that, but I need that at a minimum. Yeah.
And the thing is, this entire process requires a lot of energy from both patients and the system. And that may be contributing to burnout as well. A lot of my patients love telemedicine now because it cuts out a lot of that waste.
Yeah.
Right? It cuts out the waiting time. It cuts out the drive. It cuts out finding time for babysitting, finding a car, finding transportation, when you can just simply turn on your Zoom, turn on your video chat with your doctor. And maybe now that you've cut out so many steps in between, maybe you can expand that 5 to 10 minutes to 15 to 20 minutes.
Right. And maybe we can go back to a conversation again. Maybe I can feel like you're really a consultant. Maybe I'll really listen to you more because you're listening to me more. Maybe I feel like I get more out. Maybe I'm still getting the same pill or procedure or whatever, but I feel like I'm getting more value from this interaction. I'm more likely to do it. And less likely to yell at you, and then you go home and say, why am I doing this? Everybody's just yelling at me. Nobody listens to me.
Maybe, I don't know if that completely solves the issues of burnout, but maybe there are steps in how we can reimagine delivering healthcare to minimize burnout, and perhaps looking at where waste is in this entire process.
And aggravation. If I have to go through a menu to get somebody, wait on hold when I get them, wait weeks to get there, go through all this effort to sit there, and then sit in the waiting room, fill out a million forms, sit in the examination room, do it, waiting, and then somebody breezes in and then breezes out. And I'm like, what happened? I walk out of that experience not a happy consumer. and therefore I'm less likely to come back. I'm less likely to listen. I'm more likely to take it out on somebody, the nurses, everybody else. I'm just adding to the aggravation of everybody here. And the doctor's feeling less and less like they really got a chance to know me and figure it out. And they start wondering, why am I doing this? Why am I doing this? And the patient says, why am I doing it? Everybody's wondering, why are we doing this? I don't know. What do you think, Dr. Sue here? Is there room for hope in this? Is anybody, the Surgeon General, that's a good start. When they lay it all out, a lot of people got to get involved in this. But whose job is it to rally all those, to herd all those cats together in a room?
I mean, it's like asking, how do you make world peace?
Yeah,
I mean,
exactly.
It's a lot. When war happens, it doesn't just suddenly happen. There are a lot of things that have led up to it. Same thing with the state of healthcare now. What I can say is there are the tide is beginning to turn, because the turnover and the medical errors and the patient issues, have hit that turning point that have opened eyes. So I want to share a couple things. One at the macro level, and then one at kind of a group level.
And we'll leave this as we're down to our last minute here. So
okay, right. So the chair of my committee, Dr. Brian Dadebe, is now a Sugarman Fellow at Princeton, and he's working on a dashboard. And basically, in my words, what he's saying is, hey, look, medical institutions, you need to do a needs assessment, right? And ask the 6 journalism questions: what, why, how, where, who of burnout. What are the indicators? What are the costs? And then develop, kind of a heat map and prioritize, because you're not going to be able to spend all of the money to fix all of the problems. Right. On the micro level, we are seeing in the state of California the role of nurse practitioners starting to elevate, and their training elevate, because we have a supply-demand issue, right? There are still people becoming physicians, I can tell you, because they're in the MD, MBA programs, at least at UC Irvine. Right. So there's still, but it's not meeting the supply needs. So we have a wealth of people who are becoming nurse practitioners, where the barrier to entry is less, and you can have more people doing that who can take on some of those roles. So creative thinking like that, and creating, and looking at the systemic issues and making smart decisions with money. I mean, it's okay to make a profit. It just shouldn't be at the expense of doctors, nurses, healthcare
and maybe
providers,
taking
patients.
a long-term look at it. This is a problem with all profit-driven models. You have a tendency to focus on the immediate customer, the immediate thing right now. If I can make an extra buck now, let's do it, even though I end up losing all my physicians and burning them out, even though I end up pissing off my patients. And this isn't just in the medical world. If you just focus on the immediate buck and the immediate cost and the immediate profit, you lose some of. Am I making an investment in the long term? Is this sustainable? Can I do this forever, or am I just taking quick profits and a quick turnaround? I think that too often profit-driven organizations, because they're paid and incentivized by stakeholders, by shareholders, by everybody, they're not often thinking long-term. Not always.
There's probably some good examples of that. Going in a different direction.
Oh, the car industry
general,
and a million other.
That's how you get what you inspect, not what you expect.
Right.
Right. For sure. And the final thing that I would say is to encourage and support and boost physician resiliency. Sorry, that was a weird word. We certainly can help with some skills and capabilities that get out of that fight-flight mode. Right. By either reacting with anger or just reacting by shutting down, right? Fight, flight, or shutting down. So whether it's in negotiation skills, whether it's in communication skills and in leadership, there certainly are tools that can help them cope. It's almost like triage with what's happening right in front of them, whether it's their management, a nurse or a patient, etc. So there are immediate things that can be done too. But again, Paul, it's kind of putting a Band-Aid on a cancer.
Well, I thank you for ripping the Band-Aid off again. We've looked at it a few times. You gave us a bigger macro view of it. that example you gave from the Surgeon General to me is the most impactful, because it shows the number of people that got to get involved in this thing. It isn't just, well, yell at the hospitals, yell at the insurance providers, yell at the doctors, yell at the nurses. It's a whole group of people that have to come together and, as Dr. TRINH is saying, maybe reimagine healthcare. Maybe it is something like MD Dow in the metaverse. Maybe it is telehealth. Maybe it is a different pay model. Maybe it's something that we haven't thought of. And we continue to do things the way they are, we will continue to lose doctors, and we will continue to turn off patients, and we will continue to see costs rise. And I don't think that's what anybody wants. All right, Dr. TRINH, take us out. Good topic. A lot to talk about in one session here.
Thank you for coming on, Sue. This requires more discussions, obviously. We're just barely hitting the surface of this, but a huge topic of burnout in the healthcare community.
I'd like to have Sue come back, or others, Dr. Sue come back and talk about and break it down to some micro examples. Here's one hospital, one place, one healthcare provider, one group, one patient community service. I don't know, whatever you're going to call these different models. Here's a group that's trying something different, and see how that's working.
Absolutely. Let's do that, Sue.
Would love to.
Round two.
Thanks so much.
Thanks so much, guys. We'll talk to you guys soon.
Well, there you have it. One more example why you got to tune in, because we're trying to have the conversation. We're trying to be a place where people can at least imagine what a future looks like, where it doesn't have burnout, where it does have patients at the center, where maybe it is structured a little better. It all starts with these conversations right here on Health Talks. Streaming live on Orange County's only community radio station, octalkradio.net. Streaming live from our studios here at the University of California, Irvine's Beal Applied Innovations.